This conference will now be recorded.
Okay, so first of all, the definition, what's a rectal carcinoma? So the National Comprehensive Cancer Network Guidelines Dutch group, they define rectal cancer as the cancer which is located within 12 centimeters of the anal verge by rigid proctoscopy. And remember this problem came up because the difference in differentiation or the definition of what the rectum is between the anatomist and the surgeons, right? Remember last time we said we seek to, we rather decide that the rectum starts at the cyclopulmonary, while they decide that it starts at somewhere in between S2 and S3. So based on that, the definition is more pertinent out here. And we're talking about any malignancy which is there within 12 centimeters of the anal verge, and they're also done by a rigid proctoscopy, right? Now, just let's look at the survival rates of rectal cancer, the recurrence rates of rectal cancer. If you go by this SEER recommendation, SEER staging, which is now perhaps the standard staging method for 5-year survival rates. And SEER stands for surveillance, epidemiology, and results. I think you need to remember this because in more and more documents, papers, and textbook, now you'll come across this term SEER stage. Right. So if you look at the 5-year relative rates, with the localized disease, you got a rate of almost 89%, which is a good rate. Regional disease, that's 70%. If you have a distant disease, that emits are positive, 15%. And overall, if you look at all the stages together, it's somewhere in the region of 6-7%. By local recurrence after therapy, somewhere in the region from 3.7 to 50%. It's a hugely wide figure. Yeah. So these are the figures reported from various studies. That's why this wide disparity from 4% to almost 50%. Now let's look at the pathophysiology. If you look at the pathophysiology, 75% of these colorectal cancer. Why have we included the term colo? Because the pathophysiology of a colon cancer is identical to rectal cancer. That's why they're spoken of together. So we'll talk about the colorectal cancer from here on until we talk about the pathophysiology. Then we'll differ. Right. So 75% of these colorectal cancers, they are either sporadic or spontaneous, and there's little genetic basis. Right. Don't find a specific cause in any one of them. And most of them will be following the adenoma carcinoma sequence, which is the well-designed pathway, a well understood pathway in colorectal cancer, also in gastric cancer, which proceeds or starts as adenoma, benign adenoma, and ultimately goes on to develop into a carcinoma. So that's the adenoma carcinoma sequence. If you look at some of the causative factors, or some of the factors which are identified as perhaps stimulating the formation of malignancy, the one is the pro-inflammatory diet. And what do we mean by that? These are basically diets which are stimulating the development of a malignancy. One is high in red and processed meat. That's red meat. We're talking about the red meat is different from the chicken meat and the fish meat. So this is the red meat. Frying, grilling, broiling, or other method of cooking meats at very high temperature are again features or again things which are stimulating for the generation of malignancy. Smoking, sedentary lifestyle, obesity, and also paradoxically the other end, that's lean and thin persons, right? So both of them would be stimulatory for malignancy formation. Diabetes, inflammatory bowel disease, 2% of CRCs are related to IBDs. Alcohol intake of more than 30 grams per day. So if you're less than 30 grams, you're safe. More than 30 grams per day, you're unsafe in the sense that you'll be having an increased tendency to develop CRC. Following cholecystectomy is a well understood scenario, and the risk is mainly the proximal colon, and you have the high incidence of proximal colonic carcinoma. And the reason probably is because the bile acid which flow freely. Once you have a cholecystectomy, the storage capacity is gone. So whatever is being generated at the liver, some of it would be stored only in the CBD, some of, but the main fraction will be now in the intestines, and that increased exposure of the intestine to the bile or bile acids probably relating to the increased incidence of malignancy in the proximal colon. But here, that is the reason. So following cholecystectomy, you have the increased incidence of CRC. Now, these sporadic or spontaneous, we just want to say 75%, are some protective factors also in play, which are perhaps leading to the other end of the spectrum, that is responsible for low incidence of CRCs? Yes, there are some. Number one, daily aspirin. High fish consumption. We said red meat is stimulatory, fish consumption is probably protective, right? High fiber content, and the reason is simple, that it does not allow the fecal content to remain for a longer time in the colon, thus decreasing the exposure time between the contents and the contact with the mucosa. It also dilutes the carcinogens, right? So number one, the colon transit time and diluting the carcinogens, they both are helping by decreasing the incidence of CRC. Increased dietary intake of calcium is also slightly protective, and the reason is not very difficult to understand, because calcium binds to the bile salts and acids and resulting in the calcium salt deposition, which is antiproliferative effect and thus leads to a protective effect from malignancy. So that was 75% of the malignancy which were spontaneous, or which were where you have no genetic discrepancies which are identified. The rest 25% of the cancers are those in people with significant risk factors there, identifiable risk factor. Just now we talked about those risk factors which is probably there or not. But here we're talking about specifically identified risk factor. And they have got a genetic predisposition, right? They may be part of a syndrome such as hereditary non-polyposis colorectal cancer, responsible for 4 to 7% of all CRC cases. The FAP syndrome, responsible for 1% of all these CRC cases. It will be occurring as a separate or part of a syndrome like Gardner's, FAP, Turcot. Last time we talked about all the syndromes with which the polyps are associated, right? So these are basically the genetically or hereditary predispositions for CRC. That accounts for how much? About 4 to 8%. The rest are familial cancers, 15 to 20% of all cancer, all cases of CRC. And here, family or personal history of colorectal cancer or polyps may be found, and the relative increased risk. If you have got a parent who is afflicted, the offspring would be affected at a ratio of 2.4 to more than the normal population. And if the patient offspring with more than 2 affected first-degree relatives, then it almost doubles to 4.25. Increased susceptibility as compared to the normal person to develop CRC. So familial are the major part of these 25% where they are significant risk factors. So there 15-20%, and genetic about 4 to 7% and about 1%, right? Now, the majority of CRC are adenocarcinomas. We know that it's adenocarcinomas, and this adenocarcinoma sequence precedes the ultimate formation of adenocarcinoma. So colonic adenomas are there, and they precede the ultimate formation of adenocarcinoma. And among all these, last time we talked about polyps, about 10% adenomas will eventually develop into adenocarcinoma, but the time that they require is almost up to 10 years, right? Now, for the development of adenocarcinoma, there are 3 pathways which have been identified. One, adenomatous polyposis coli, gene adenoma carcinoma pathway. We'll be talking about that. Number 2, hereditary non-polyposis colorectal cancer, HNPCC. And the third, that is ulcerative colitis dysplasia pathway. So remember 3 pathways for the development of rectal carcinoma. The first pathway, which is the APC gene adenoma pathway, it involves several mutations. It's not only the APC gene which is involved. So a number of genetic mutations which are together they ultimately go on to form the malignancy. And they start with what? APC gene inactivation. If once inactivated, what happens to the body? It allows unchecked cellular replication at the crypt surface. Okay? So APC gene mutated, unchecked cellular replication at the crypt surface, leading to what? Increased cell division and further mutations occur. What further mutations? They lead to activation of KRAS oncogene in the early stages and P53 mutations in the later stages. P53, we all know, is a suppressor gene, right? So now what has happened? APC gene inactivated, lead to activation of KRAS and P53 mutations. So now you've got 3 mutations occurring out here: APC, KRAS, and P53. One depression, the other 2 stimulate, right? These cumulatively lead to what? A loss in the tumor suppressor gene function, preventing what? So once you don't have any suppressor activity, the apoptosis is affected and the cell lifespan is increased or prolonged until indefinitely. So the the suppressor gene and the apoptosis, which was supposed to be functioning, is not functioning. So that cell, which may be a mutated cell, which may be a damaged cell, keeps on multiplying more and more and more. You should have been checked. So ultimately, what's happening is a unmitigated um, multiplication of the defective cell, right? This APC mutation, if it is inherited, it will result in the familial adenomatous polyposis syndrome, FAP syndrome, right? Histologically, these adenomas, last time we talked about the classification of tubulovillous, and villous adenoma, right? And they can even be seen to have a plastic polyp. So basically, we're talking about is adenomatous polyp or even hypoplastic polyp, which can ultimately go on to develop a CRC, and it is passing through the genetic pathway, where leading to inactivation of APC and stimulation of KRAS and P53 mutation. Is that clear? Right. Coming to the second common pathway, which is mutation in the DNA mismatch repair genes. Right. So this repair gene does what? Whenever it finds a DNA mismatch, it repairs it. Now, if there's a mutation in that gene, which is supposed to be a gene which is controlling or which is correcting the mutation DNA, ultimately is going to happen, the DNA repair gets affected. And if it gets affected, what's happening? The mismatch of DNA would occur. These mutated DNA keep on multiplying inside the body. So what is happening? This error, this application error is found in 90% of HNPCC and 15% of sporadic colon rectal cancer. Even sporadic 15%. But majority of this, the mutation in this repair gene is found in 90% of genetic, especially HNPCC. And these mismatch repair genes have been identified. Let's forget what these genes are. You can look it up again in the slides, right? So the second common pathway is what? Mutation in the DNA mismatch repair gene, which is going to affect the DNA repair. The third pathway, which is especially seen in IBD by inflammatory bowel disease, is basically what is happening is chronic inflammation, like for example, ulcerative colitis, leading to what? Genetic alterations. Leads to what? Dysplasia. Leads to what? Ultimately malignancy. So that is the pathway. Inflammation leading to genetic alteration, leading to dysplasia, leading to formation of malignancy. In ulcerative colitis patient, it will be developing after 10 years, and the rate is 1% malignancy per year. After that, Crohn's after 10 years and 4 to 20 times than in the general population. So both these inflammatory bowel conditions are to a certain extent are pre-malignant, right? So what are the genetic mutations that you find in CRC? We're talking about those. The WNT signaling pathway mutations, what is usually seen in APCG. Mutation P53, we just talked about the last slide. Overexpression of certain oncogenes like KRAS, we talked about that last time, and the RAA for rapidly accelerated fibrosarcoma. That is group 1. The second group is what is known as epigenetic alteration. This is a genetic mutation, epigenetic alteration. What are these epigenetic alterations? These are basically the alternate pathway for the development of the malignancy. If you remember the last lecture, we said that the serrated colonic polyp or serrated adenoma, they always lead to formation of CRC through the epigenetic alteration. So what is epigenetic alteration? These are basically the cellular environmental factors which ultimately affecting the gene function and morphology. So it is not a primary genetic effect. Some cellular effects or some environmental factors ultimately lead to the gene alteration. And what kind of gene function alteration and morphology? Ultimately leading to generation of malignancy. This would be known as an epigenetic, right? So based on this, when do you require a screening for malignancy? That is one of the most important things to be remembered. One, if there is a family history of colon rectal cancer, immediately go ahead and start screening this patient by regular colonoscopy. For the relative with adenoma, age younger than 60 years, again, you would be doing a colonoscopic follow-up. Genetic cancer syndromes, hereditary non-polyposis colorectal cancer, familial adenomatous polyposis. So these are all the some of the conditions in which you would like to follow the patient with a regular colonoscopic examination, right? Epidemiology of CRC. One, high incidence of colorectal cancer are identified in the more developed industrialized countries, like for example, US, Canada, Japan, Europe, New Zealand, Israel, Australia, and the lower CRC rates in Algeria, India. So basically, we have a CRC with incidences very low, right? The majority of CRCs are found in industrialized countries that we just now said. Age incidence starts to increase after 35 and rise rapidly after the age of 50. And when does it peak? Seventh decade, right? So that means more than 90% of colon cancers occur after the age of 50 years. But now the trend is what? We are finding increasing incidence in the younger patients which are below 50. Racial, more in blacks, and the mortality too is more in the blacks. Sex is slightly higher in males. Right? Now, pathological types. Apart from those listed in benign polypoid lesions, like now we talked about the tubular villus, serrated, and so on and so forth. Apart from that, the adenocarcinoma that are identified in almost more than 95% of these patients could be any of these types. Like, for example, a cribriform comediotype, medullary carcinoma, micropapillary, mucinous adenocarcinoma, which produces a lot of mucus, serrated, and cigarette ring carcinomas. So all these can be found in these patients with a CRC. The second type of malignancy that you find is adenosquamous. The third, spindle cell carcinoma. The fourth, squamous cell carcinoma. And the fifth is undifferentiated carcinoma. Looking at it from a different aspect, macroscopically you find either ulcerative growth, a polypoidal growth, or a infiltrating. Microscopically, you just now said, apart from the adenocarcinoma, you can have the spindle cells, squamous, undifferentiated, lymphoma, carcinoid, malignant melanoma, benign condition, mimicking this condition, and of course the gist. Right? How does it spread? Number one, direct. And this direct spread could either be circumferential or could be longitudinal. One thing which is good about this malignancy is it tends to develop upwards, hardly ever develops down in the anal. Right? So if you have an anal tumor, then please think of an anal malignancy before you jump on the bandwagon and say, no, this is not an anal malignancy, this is anal malignancy, that it should be the rectal malignancy gone on to the anal malignancy. Right? Second method is lymphatic. The third, vascular, and the vascular sites are number one, liver, 33%, slightly less lungs, and slightly more adrenals, and remaining to the rest of the body. And of course, the fourth method of spread is transperitoneal. Okay, so the method of spread. The second is, or rather, the first is, we are still connecting the first one, and that is the direct spread. Maximum of 5 centimeter dysteria. And this is an important detail. You have to remember that. Radial extension through the wall goes into the mesorectum and then through the mesorectal fascia, infiltrating the surrounding structure. So remember yesterday we said, day before yesterday we said, we are basically talking about a cylinder which is surrounding the rectum. A cylinder in which the rectum is lying. And the walls of the cylinders are what? Basically the mesorectal fascia. And you don't have to transgress. You cannot transgress the mesorectal fascia. You have to do an excision. Yes. Right? Right? Posteriorly, the mesorectal reaching outwards. And later, thank you. Can you please switch on the mic? Whoever has got the mic on. So the posterior limiter of the fascia voltae, you remember the anatomy that we talked about, the first lecture that we had on rectum, and beyond the fascia voltae, we all know is a fascia which is not presacral, and once it breaks to the confined presacral, it goes on to the sacrum. The intrapetal part of the rectum, which is basically totally intrapetal, is what? Upper third, right? The direct spread which is occurring is going to be transperitoneal dissemination. The extraperitoneal, that's the lower third. The anterior spread is easier and more frequent because readily penetratable denovilous fascia. Now, in contrast to the fascia voltae, denovilous is a pretty weak fascia. So, it is readily penetratable. And males, it will go into the posterior seminal vesicles, and females, what is lying just anterior, the posterior vaginal. Laterally, will spread goes into the ureter. That's the direct spread for you. Now, coming to the rectal part of the direct spread, this was beyond the confine. Now, primary circumferential, just now said that. I think we already did that. I'm sorry. Right. Now, lymphatic spread. The lymphatic spread, we talked about the lymph nodes, slightly referred to them in the class on the lecture on surgical anatomy. Here, let's look what is happening. More distal rectal tumors tend to have more lymph node metastasis and more lateral lymphatic spread. So, this is some of the overview of the lymphatic spread, right? Tumors, if they are more than 3 centimeters, they show more lymph node metastasis compared with those smaller than 3 centimeters. So based on just having a macroscopic view of the tumor can help you decide whether you're really looking at a lymph node metastasis or not. The depth of bowel invasion is also important and strongly related to the presence of lymph node metastasis, and goes logically on to say that the more deeper the penetration, the more the chance of lymphatic. The peritoneal reflection has no discriminating node. So you can't say that the upper third has got a peritoneal covering, it will be more lymph node positive, and lower third, which is purely extraperitoneal, will have less lymph node positive. That means the peritoneum has got nothing to do with the lymph node positivity. Intraoperative assessment by the surgeon for the presence of lymph node metastasis is not reliable. It's not reliable. See, so once you operate, you say, I don't find any lymph node positivity, it's not really reliable. Investigation have to be done. Now, when localization, depth of bowel invasion, and diameter rectal tumor are known, a likelihood of lymph node metastasis can be assessed preoperatively, not intraoperatively. That's what I was saying. When you have a macroscopic view of the tumor, whether you're doing colonoscopy or you're doing basically, let's say, MRI or a CT scan, you can, even if you don't find a lymph node metastasis, if you find the growth to be such as more than 3 centimeters, you can really say that probably in this patient, I will be encountering lymph node metastasis. Right? So whenever lymph node metastasis occurs, it occurs into 3 groups. One, the immediate perirectal group, right? Then you have the intermediate main lymph nodes, and subsequently go the lateral pelvic lymph nodes, which are basically lying along the margins or along the walls of the pelvis, of the true pelvis, right? And the intermediate main lymph nodes are basically which are found along the superior rectal and ultimately the inferior mesenteric vessels, right? Now, there are 3 zones: zone of upward spread above the peritoneal reflection along the superior hemorrhoidal vein. I just told you that, to the inferior mesenteric glands. Rarely a discontinuous spread occurs, but usually follows a route. And that upward spread, even from middle third, it is ultimately going where? Into the lymph nodes around the inferior mesenteric, right? Lateral spread below the peritoneal reflection, that means we're talking about the middle and the lower third, up to 1 to 2 centimeters from the anal wall. That means it's also covering the upper part of the anal canal, right? That means above the dentate line, right? So this, the first stoppage is always at the pararectal glands of Giroda. So the upper third straight away up. The middle third, it is going laterally, and from lateral, then it goes up, right? And from this lateral, some of it goes to the wall of the pelvis. So it's very simple. It's very simple. You have basically the rectum, upper third, middle third, lower third. Upper third straight away. Middle third, part of it lateral. From the lateral goes up. So these pararectal group of the rotas would be sending the lymphatics upward again towards the superior hemorrhoid. But 20% of them are from here would be sending it to the margin of the bony pelvis, right? And there it will be internal iliac. From the internal iliac, ultimately it is going to go to the para-aortic. From the inferior mesenteric, it goes to para-aortic. So the ultimate stoppage is para-aortic. And from the downward spread, once you have the sphincter complex involved or the perianal skin involved, ultimately you have the superficial inguinal gland. So remember, in the rectal carcinoma, having a inguinal gland positivity, it should be a rarity, in the sense that it would basically mean that it's gone into the anal canal. But we just remember that spread of malignancy, rectal malignancy downwards is not a common phenomenon. It is always mainly upwards. So longitudinally, when the rectal carcinoma is spreading, it is always upwards, very rarely downward. So if you believe it's really downwards, then except for the fact when you have the utmost lower margin of the lower third. If you have this lower third, you're just getting involvement of the lower third where the junction of lower third and anal canal. That could be the only condition where it could be involving the superficial inguinal lymph node. Is that clear? Looking at the symptoms and signs, I think we all know about it. The usual age around 55. Early in syndromic manifestation, like for example, if the patient had first the father involved or a second offspring involved, in these cases, the age could be much less, but otherwise around 55. The symptoms, the PR bleed, the hematochezia is there. In addition to this, you have a sense of incomplete defecation. Now we are speaking not to the CRC, to the rectal carcinoma. So up to that part, it was CRC, the colorectal cancer. Now it becomes separate, and we are moving away from colorectal cancer, and we are being more specific about the rectal cancer. So hematochezia is a common occurrence. The sense of incomplete defecation, the tenesmus, especially when you have the lower half of the rectum involved. The altered bowel habit. The patient could be constipated, the patient would diarrhea. Constipation would be seen only in those patients where it is a circumferential growth causing an obstruction, right? So it could either be a subacute sinus obstruction or a superimposed acute sinus obstruction. Again, altered bowel habit, the diarrheal part could be manifesting as an early morning diarrhea or a spurious diarrhea. We talked about what the spurious diarrhea mean yesterday, because the early morning diarrhea is basically a manifestation of spurious diarrhea. Spurious diarrhea basically means what? It is just a accumulation of mucus from the growth. So increased mucus secretion on the mucus of the growth, and that keeps on accumulating in the night because the patient is sleeping and lying down. It keeps on accumulating, so that in the morning he has got a heavy load inside the rectum, and that heavy load is built up of what? Just blood and mucus. So the first defecation that the patient does in the morning consists of what? Just mucus and blood, right? So early morning diarrhea, which is a spurious diarrhea, is basically the accumulated content. But that spurious diarrhea, which has got minimal fecal content, more of mucus and blood, could be done throughout the day also. So it's just not different. Two things are not different. It's just a type of spurious diarrhea. The only difference is the volume is much more in the early morning diarrhea. Is that clear? And then, of course, the patient will be coming to you with a lump, lump in the abdomen, which is a liver lump, and that is seen only when the patient has got meds. If you're doing a DRE, it's very, very important for rectal carcinoma. Things that you should know. Number one, when you're doing a DRE, your average finger, not with those who have got very long fingers, an average finger can reach approximately 8 centimeters over the dentate line. Right? Is that clear? And that is more possible if you're doing it in a knee elbow position. That means you can reach the highest point of the rectum in a knee elbow position. Number one. Number two, what are you looking for in the rectum? Number one, you're looking for the size of the growth. As regards what? The longitudinal extent and circumferential extent. An initial belief when we were taught was that if it is circumferential extent, it is almost there, it has been there for almost 18 months minimum. That what we were taught, but in the new textbooks this is missing. But if you want to remember it, that if the growth has already spread circumferentially, it means 18 months of existence minimum, right? Longitudinally, you have to see if you can reach the upper point, highest point or not, and can you palpate the lowest point or not. Whether the finger can be negotiated beyond the growth. There are instances where it becomes circumferential and to such an extent it's causing obstruction, and the finger cannot be negotiated through the growth. Number two, what are you looking for? Ulceration and bleeding. Assess if the growth is ulcerated. Assess whether the finger, when you withdraw the finger, it is stained with blood or not. Possibly presence of pararectal lymph nodes. Why possibly? Because that is a different thing, difficult thing to be assessed just doing a DRE. But fixation of the tumor can easily be done. Fixation to what? The mucosa of the reaper layer. So try to move the growth just with the help of a finger. You're not going to insert your hand inside the anal canal. It's just a finger that's So just try to move with that finger. You can get a distinct impression whether you're able to move it on the deeper layer. So deeper layer fixation. Number two, the superficial fixation to the some mucosa, and then of course to the deeper layers. Anteriorly try to move it over the posterior vagina. Posteriorly try to move it to the sacrum. That will give you an idea whether it has gone beyond the serosa into the deeper layer. That basically means T4 level. What else do you want to see? Fixation to the sphincters and a cursory evaluation of the patient's sphincteric function. May or not be assessed, may or may not be assessed, but you can easily see whether the sphincter complex has been involved. We are palpating the anorectal ring. You can do that. We palpate the anorectal ring. So we find the growth to be encroaching on the anorectal ring. We are sure that it involves the sphincter. External sphincter can be assessed by just seeing the anal tone and the puckering around the anal opening. Right? Clinical implication, one is thing is very clear. Deeper, I told you the implication is T4 growth. What about the extent? If the growth is palpable on DRI, that basically means lower third of rectal involvement, and there you have to, more often than not, you have to go in for a APR. So the principle or the dictum is that if the growth is palpable with your finger, it is likely to be amenable only to a APR or abdominoperineal excision. Resection, right? Now, the initial evaluation, the diagnostics and staging, I found this chart to be very helpful, so I picked it up. Initial evaluation, when the patient comes to you, you do a colonoscopy, take a biopsy, and send it for histopathological review. That should be the primary thing. The colonoscopic view and assessing the growth, size, and whether it's mobile or not by doing the saline lift test that we talked about last time, and then take a biopsy and send it for histopathology, right? At the same time, that means the primary growth. At the same time, try to assess whether it is spread beyond the confines or not. That's the metastatic evaluation. In the form of what? Chest, abdomen, pelvis, CT scan. After all, where does it go? We just now said that. Lymph node to the liver, to the lungs, right? So all abdominal lymph nodes, whether it is the inframesenteric, whether it's the paraortic, and so on and so forth. Number two, the CEA level and the liver function test, which will give you an idea to the liver mets. CA level, incidentally, you know that the level of CA in these patients would be as high as 100 nanogram per ml. The normal is in the region of less than 2.5 in non-smokers and 0.5 in non-smokers. So almost increased by 50 times or 100 times, right? Pre-surgical evaluation then comes in. PET scan is not routinely indicated. Why? Because once you have because PET scan is not going to tell you anything except for the fact the degree of spread. That has to be done by the chest, abdominal, pelvis CT scans. PET scan does not come into play at this point in time. Endorectal ultrasound or endorectopelvic MR will tell you about the end staging and the T staging of the growth. Right? Especially the endorectal ultrasound would be a very good method of assessing the T staging. Pre-surgical evaluation, what that going to tell you? The digital rectal examination, we just now referred to that. A rigid proctoscopy, we said that. Clinical decision making regarding primary or adjuvant chemotherapy and radiotherapy. So once you have this, once you have all this data, then you have to decide pre-operatively that whether I want to go in for a primary surgery or whether I would like to go in for primary chemotherapy and radiotherapy and then go ahead with surgery. Just tell you what the principles are. And you have to take the help of an enterostomal therapist, especially when you're planning to creating a stone. So that should be a pre-operative marking of site. He'll tell you, make the site here. So that has to be an essential part of the diagnostic and staging evaluation, right? If we look at the staging, you've got the Dukes, modified Dukes, the TNM, and if you attach Y to the TNM, it is basically telling you that it is a new adjuvant, a subsequent new adjuvant. You're doing a staging, then you call it whatever stage you call it, you always apply a suffix of Y, right? Histologically, so that when you're doing HPE, you did an HPE, you took a biopsy and did an HPE. So what are you looking for? Number one, you have to see the degree of differentiation from G1 to G4. Well differentiated or undifferentiated. We all know that, the Borders classification. You always have to look for primary mucoid endocarcinoma. They've got one of the worst problems, mucoid endocarcinoma. And what are you looking for? Signet ring type. That's intracellular mucus, which is displacing the nucleus to the periphery. So it just looks like a ring, a circle with the nucleus lying on one side. That is signet ring type. The vascular and perineal evasions seen on HP, especially with deeper biopsies taken through the colonoscope. That is what you're looking for an HP, right? The Astley-Kohler modification of the Dukes, which is now in force, that is the most commonly followed. Very, very simple. When you talk about A, you just link the mucosa. See this figure? When you talk about B1, you've gone with some mucosa. B2, you've gone into the muscularis mucosa. That's the muscular property, right? But it has not gone beyond the serosa. Just add the lymph node to B1 becomes C1, B2 lymph node becomes C2. Simple, right? So when you got a B1, when you got the submucosa and just encroaching on to the muscular layer, it is B1. If you find lymph node along with this, it becomes C1. B2 just beyond the muscularis, the propria, and just onto the serosa, add lymph node to it, C2. And anything beyond that is a lymph node, is a D stage, right? So that is the Astley-Kohler modification. Now coming to the classification, and that has to be the venous invasion, whether the patient has got microscopic venous invasion or not, macroscopic venous invasion or not, V1 and V2. Lymphatic invasion, L0, L1. So if you look at the T staging, I'll just refer to one or two points here. I'm not going to enumerate everything, as is common everywhere. T1S tells you the carcinoma is C2. That basically means it is only in the epithelium or lamina propria. Now, when it's the submucosa, it becomes T1, which was identical akin to the P1 Dukes, right? T3 is basically muscular propria into the subserosa, but not beyond. That is B2 Dukes. So there is a comparison between the two. But here it is much more specific. That means where you've gone to the visceral peritoneum, we like to call it a 4A. Other organs, you like to call it 4B. Similarly, the end staging, and now most of the end staging for most of the organs is now referring to the number of lymph nodes. Number of lymph nodes. Like example, remember we talked about the gastric cancer, we talked about the gallbladder cancer. Initially, we used to talk about what? The CBD lymph nodes and then the supra-pyloric lymph nodes, so on and so forth. But now it is the number of lymph nodes. So here also, 1A is 1 regional, and 1B is 2 to 3 regional, 2A 4 to 6, and here 7. Right? So this is basically, I'm not going to go into the details of that. This is basically how you look at the regional lymph nodes. Here also M, 1A, one organ, 1B, more than one organ, and 1C onto the peritoneal surface. So all of them have been subcategorized into the various subgroups. Go through this in your free time, right? Remember them, but it has to be remembered. I'm not wasting time out here. So let's go on further. So coming to the treatment modalities, the surgery, the radiotherapy, and chemotherapy. 3 prime modalities. Among all these, surgery is basically the treatment of choice if possible. Let's look what are the principles of surgery. Number 1, a curative surgery basically would mean what? A radical excision of rectum. So what does that mean? Radical excision of rectum, when it is radical, it would be known as what? 3 centimeters of normal tissue from the below the distal cancer margin. When you talk about the upper third of the rectal sigmoid or the rectal sigmoid junction, that means the upper third, middle third, lower third. So it's the upper third of the rectal sigmoid here. If you want to do a radical excision, I would be going 3 centimeters. If this is the distal part of the growth, 3 centimeters below, right? Below the distal cancer margin. But if I'm talking about the same middle and lower third, I really don't have 3 centimeters to play about with. So what am I reducing it to? 1 centimeter. So if you talk about the lower 1/3 of the rectal growth, it is at least 1 centimeter of distal normal tissue. Is that clear? So that is the difference. The upper third and probably to a certain extent the upper. So let's talk about the upper half and lower half. That means part of the middle third taken with the upper third and part of the lower third, middle third taken with the lower third. So the upper half, you can play about with 3 centimeter normal tissue below the distal cancer margin, and at least 1 centimeter when you talk about the lower third of the rectal growth. That is one. Number 2, what else do you add to it? Mesorectum. What else? We talk about associated lymph node and mesentery. And how do you do that? By tying the inferior mesenteric artery at its origin and inferior mesenteric vein at its termination. So you have to do the dissection up to there. If you're doing it, you're removing adequate amount of mesentery. If you're doing that, it brings along with it adequate number of lymph nodes. If the mesentery is being brought down, you are getting adequate lymph nodes. So associated lymph nodes, the mesentery, mesorectum, and radical excision of rectum. Right? What about liver metastasis? Initially, we were taught we said liver metastasis, gone case. Don't even think about it. Yes, it can be excised, and curative resection of liver metastasis can be done. We're not going to go to the details when and how it's being done. Let's see if in one of the future slides we can talk about it. Locally advanced, that means T4 staging. Probably not amenable to primary surgery. So what do you do in these patients? Downstage with neoadjuvant radio and chemotherapy, and then if possible, excising. Early T1 and some T2. More surgery, organ-saving surgeries are now coming to force. Like for example, organ-preserving TEMs, brachytherapy, contact radiotherapy, when it is the less mutilating kind of surgery. You're not really excising anything, just cutting the mucosa part or some mucosa part. T1, T2 is basically means that. Is that right? So it is a TM or a brachytherapy contact radiotherapy. Palliative, when you're talking about a T4, let's say N1 and 2, in these cases, or N3, this patient is inoperable. The patient, you cannot do anything even after downstaging. So what do? You give the patient relief by the obstruction. And how do you do that? The stent endoluminal. So endoluminal stenting, endocavitary radiotherapy, chemotherapy would be working in those patients who are inoperable. Or you can do external beam radiotherapy in these patients, right? How do you prepare the bowel? Now that is true for any kind of malignancy or for any kind of colon surgery or rectal surgery. But here it is more important. And what are we looking at? We're looking at a combination of two things. Then prepare the bowel for rectal carcinoma, mechanical bowel preparation, MBP, along with oral antibiotics or parenteral antibiotics. Now, MBP basically mechanical bowel preparation. What has become the standard is the polyethylene glycol given 24 hours before surgery so that most of your contents of the colon go out. Or it could be a combination of magnesium citrate or magnesium sulfate along with a P. So it is all relying on polyethylene glycol. Initially, it used to be a total wash. Used to put in an ice tube and connect to a saline, make the patient sit inside the bathroom on the pot, and you keep on pushing saline in through the ice tube until the patient starts passing saline. Very cumbersome, for the patient. No longer done. Just give this patient PEG, 1.5 2 liters, right? The antibiotic can be given orally or parenterally, or it could be combination of. A preference is given to a combination of promycin, tetracycline, erythromycin, oral, and 3 times, 1 p.m., 2 p.m., 11 p.m. on the day before operation. That means I'm going to have my operation tomorrow. I'll be starting today afternoon, 1 p.m., then 2 p.m., and then 11 p.m. before I go to sleep. Tomorrow I have, or I can be antibiotic therapy, etroxime plus metronidazole makes a combination, can be combined with lincomycin, can be combined with gentamicin, what you want to choose, right? In relatively clean cases with soiling, I've done surgery and I have some kind of a soiling, one of the clamps came off, what else should be done? Cephalosporins could be continued for a longer period of time, not only the preoperative, for a longer period of time. Local antiseptic application should be made available where the leak has occurred, where the spillage has occurred, and peritoneal wash should be done by normal saline. Simple normal saline, an adequate peritoneal wash should be done, or you can use a metronidazole solution, right? Now, what is the curative surgery for rectum? We just now said 3 centimeters and 1 centimeter. So upper 1/3 of the sigmoid, that basically means 12 to 16.5 from the ill margin. What surgery can I do? Which can include the 3 centimeters or 1 centimeter. A high anterior section, right? So the rectum, what you do is known as a high anterior section, right? HAR. For the middle third of the rectum, you call that curative surgery as a low anterior section. For a lower third of the rectum, that rectal excision. So we said in this radical excision of rectum, we said 3 centimeters, 1 centimeter. But what is that known as radical excision of rectum? When you talk about upper third, it will be known as high anterior section, middle third, low anterior section. When you talk about the lower third, middle third, low anterior, lower third of the rectum. If you've got 2 centimeter normal rectal margin, you can go ahead and do a sphincter saving resection or a very low anterior section and other procedures. This is a very low anterior section, right? Along with this, it's a very low. Or you can do a sphincter saving resection. But if you don't have, or even if you have a less than 2 centimeters, if you don't have 2 centimeters, right? 2 centimeters good enough. Not 2 centimeters, you can have 2 scenarios: a T1, T2 lesion, less than 2 centimeters with a T3, T4 lesion, right? So the differentiation in the lower third can be made on the 2 centimeter normal or less than 2 centimeter normal rectal tissue before going on to the rectum. That means just below the anorectal ring. Understood? Very clear. So lower third of the rectum, if you have 2 centimeter normal rectal tissue above the anorectal ring, clear? Then you're doing what? A sphincter saving resection or a very low AR and other procedures. But if I don't have the 2 centimeters of the anorectal ring, now what do you do? Two scenarios. I have a T1, T2 growth. I can go ahead and do an intersphincteric excision. I'll tell you what this means. Or local form excision. But unfortunately, I don't have that 2 centimeters and I have a T3, T4. No option, just APR. Is that clear? So that is the principle of surgery. The curative rectal excision is basically either a high anterior section, a low anterior section, a sphincter saving resection, very low anterior section, intersphincteric, local excision, and APR. So this figure you should remember, this differentiation you should remember, right? Now, more further. Early mucosal growth, T1 and T2. We said T1 and T2, you can go ahead with local forms of excision. So what are these local form excision? The local form excision is a transanal resection. Early mucosal growth T1, T2, a transanal resection. One of the possibility, one of the very good possibility. A preferred curative external surgery should always be what? A TME. That means a total mesorectal excision done abdominally by laparoscopy or open. We said this. What are these HAR, LAR all about? Very low AR. What is this all about? This is basically resection. When you say any kind of resection for the rectum, we just said it has to include the mesorectum. So it has to be a total mesorectal excision. Understood very clearly that we open the abdomen and do it. But can we do the same thing transanally? Can we do a mesorectal excision transanally? Yes, that's known as a bottom-up approach. And here we are doing everything through the anal canal, and we're removing the hole on the mesentery. That means, remember, we're removing the whole cylinder. Which cylinder are we talking about? The mesorectal fascia, along with the mesorectal fascia, along with the mesorectum, and inside the rectum. Remember that the cylinder, the rectum, around the mesorectum, and the mesorectal fascia. So that cylinder we're talking about, the whole cylinder has to be removed as such. So we can do it by creating an opening to the posterior of the rectum, going in and do complete excision, and then removing everything. But it could also be done as a combined synchronous approach. That means I do the mobilization from the abdomen laparoscopically and I remove it everything below by going through the posterior rectal wall, incising it and approaching into the pre-sacral. So laparoscopic abdomen mobilization with the transanal approach would be known as a combined synchronous, or I could be doing a bottom approach if I want to do a transanal total mesorectal excision. Right? What about this T4? We talked about this T4. See, T3, T4 growth APR, that's one. Could there be other methods to it? One, I can downstage it. How? I can do a radiotherapy for 5 days, or I can do a radiotherapy, a chemoradiotherapy, that means radiotherapy for 6 fractions plus a 6-week period of chemo. Then I wait for adequate time and then I follow it up by surgery. That's the option for a T4 growth. This T4 growth we're talking about. Less than 2 centimeter rectal margin, or even higher up. Let's say I have a upper 34 or I have a middle 34. And that I find that I'm not able to excise it. So what do I do in that case? So any T4 of any part of the rectum with a local extension as T4. See, any part of the rectum, local extension T4. What do? I do a downstaging and subsequent downstaging, then I excise it. Right? The other thing that has to be remembered at all times is that whenever I'm doing a rectal excision, short of APR, I would always like to preserve what? Number one, sphincters. If I don't preserve the sphincter, that patient becomes incontinent. In addition to this, what my aim should be that I should prefer to retain some amount of the rectum. Why? So that it becomes a coloanal anastomosis with some part of the rectum. Why? Especially pertinent for the lower third of the rectal growth. Why? Because that prevents the risk of anterior resection syndrome. What is the syndrome all about? Defecatory urgency, incomplete evacuation. And that is why it says that preservation of part of the rectum is better, less risk of anterior resection. So if at all I'm trying to do a curative surgery, the lower third, I would always like to retain the lower margin of the rectum so that I can go ahead and do a colorectoanal anastomosis. Right? If I'm doing a direct coloanal anastomosis, I'm going to the sphincter. and then I will not be able to retain the defecatory urgency would be there and incomplete evacuation would be there. Why? Because the patient going to suffer with the anterior resection syndrome. Further, for principles of surgery, what about hepatic metastasis? Not a contraindication for curative resection, which seems to be a logical deduction. The logical extension of your thought would be, if the patient has liver mets, no curation possible, no curative surgery possible. No, it's not that. You can do a curative resection and you can also do a resection of the part of the liver, depending upon what kind of liver mets you have. Another important principle, what about rectum sphincter saving? Saving forms of local destruction or excision, especially favorable lesions, which include what? Now, we have been talking about those lesions where you can save the sphincter and not cause too much mutilation of that particular part. What are these indications? Number one, if you have growth of the lowermost 10 centimeters of rectum. Agreed. If you got a small size, less than 5 to 6 centimeters, should be exophatic growth. Mobile the deeper muscle, that basically means what? T1, T2 growth. No node should be palpable through the wall. Biopsy should show well differentiated growth. And patient is, if it is in poor general health, then he has to have a local form of destruction. So we are talking about local forms of destruction or excision, especially favorable lesions. So these are favorable lesions. And we can think of saying that I could go in for a local form resection rather than going for a complete rectal excision. Right? Now, if you look at the low anterior section, the LAR, which now becomes probably the benchmark on which you base all kinds of carcinoma rectum surgery. So what are the principles? We said radical excision, mesorectal, and I think we already talked about this, that you should go in for a excision of the inferior mesenteric artery and vein up to that particular, sorry. Now this is what TME looks like. See this, we talked about the mesorectum, and that is basically the mesorectal fascia. See the fascia? So what are we excising? This whole cylinder is excised. The rectum, the mesorectum, and the fascia. That becomes a cylinder. And removing up to what part? Removing right up to the levator and the rectal ring. Right? So that is basically a TME of the lower third of the rectum. Now, what are the local? We are talking about T1 and T2. So how do I do it? How do I do it? Local destructions. What are the options available with me? I see a T1 growth or T2 growth. I would decide that, look, I'm not going to do any kind of rectal excision. Let me just excise this mucosa, especially where in those favorable. I just talked about these favorable part. So I'm fortunate enough to encounter a patient with this kind of presentation. I decide I like to go in for a local form of excision. HP is a must as a good prognostic pathology. We said that has to be a prerequisite. Lymph node probability with T1, have to look at that, and that is around 10%. With T2 growth is 20%. That has to be taken into account when you're talking about a local form of destruction of a T1, T2 lesion. The chances of lymph node positivity is just 10%, but then that has to be kept in mind. Why? Because we have to deal with that later on the post-mortem. And what are the modes available? The various modes available are number one, transanal TME. We talked about that, transanal TME, but short of that, for more protective kind of a surgery, I can do electrocoagulation. I can do electrocoagulation, and I can do a repeat fulguration if required after 3 months, for 6 months. And the 5-year survival rate is not bad, 68% if I go for local fulguration. I can do endocavity contact radiation using 4,000 rads for 3 minutes at a time, and the 5-year survival is again 72%, slightly better than this. So these are not bad 5-year survival figures. Or I can go for local excision. It's inferior to both because of increased morbidity, and 5-year survival is still questionable. So I've got 4 options to do when I'm doing a local form of destruction. Either I do a transanal TME, I do electrocoagulation, I do endocavity contact radiation, or I do a local excision. These are the options available with me if I'm doing a T1, T2 lesion treatment. Carcinoma rectum, what about the inoperable cases? Now, I've done everything, I've done all kind of staging, and I find I can't operate this patient. This patient has got basically spread all over the pelvis. So what can I do? I can do Hartmann's with end colostomy. Now, basically Hartmann's with end colostomy could be translated to 2 types. One, the real Hartmann or the original Hartmann was excision of the growth, closing the distal part of the colon of the rectum, and bringing the part of the colon as an end colostomy. That was the original Hartmann's. But there could be a scenario, like for example, a frozen pelvis kind of a spread, and I can't do anything. So I just do what? I just close the upper end along with the growth. I'm not excising the growth, and I do an end colostomy. right? So the choice of operation will depend upon, number one, it will depend upon the staging of the growth, the spread of the growth, also upon the age, sex, and build of the patient, right? So as said earlier, the selection of procedure preoperatively can be made after the investigation, but as a general rule, even after clinical examination, you could say that I'm going to do APR or not going to do APR based just on a DRE examination. We already referred to that if it's palpable DRE, probably not amenable to other methods, it has to be an APR in these patients, right? Now, what are the sphincter saving resections that we talked about? We talk about sphincter saving, sphincter saving, sphincter saving. A low growth, like for example, this growth. In this patient, can I save the sphincter? I can. The sphincter complex is not involved. So what are the sphincter saving operations available? Number one, the low anterior section or very low anterior section. Talked about that, right? I go for very low anterior section. I just use 1 centimeter, 2 centimeters of the rectum, and I do a colorectal anastomosis. That is sphincter saving. I have not touched the sphincter. Or I can do abdominal anal pull-through operation. That means I do excision, I drag everything down after mobilization, and I do excision. A Park's abdominal transanal technique, abdominal sacral resection, York Mason abdominal transsphincteric resection. So these are some of the saving sphincter saving. How I'm saving the sphincter? Because when I'm doing everything transanally, I'm bringing everything down, I'm doing excision and then pushing everything back. I have not touched the sphincter at all. So all these are basically what? See, transanal, pull through, sacral, and abdominal transsphincteric resection. So all these are the sections where the sphincter has not been touched. But now probably the intersphincteric excision for a very low rectal cancer is now become the treatment of choice. I'll just show you what this basically means. So as far as we are concerned now, we forget about all these because these are more of historical importance now. They're not usually being followed. What is being followed is a very low anterior section and intersphincteric excision for a very low rectal cancer. These are the sphincter saving resections as of today, right? What are the intersphincteric excision for very low rectal cancer inclusions? Number one, tumor located 30 millimeters from anal verge, 15 millimeters from dentate line, 1 centimeter above the anal rectal. See, we are having what? 1 centimeter rectal margin. These are the patients who qualify for a sphincter saving surgery. Why? Because this patient does not even have 1 centimeter margin, right? Local spread restricted to the rectal wall or the intersphincteric area. Adequate preoperative sphincter function and continence has to be there, and there should be absence of distant metastasis, right? So this would together lead to what? This would be making the group of patients where you really think of an ISR, right? So these are the group of patients where ISR can really be thought of. Contraindications to ISR, intersphincteric dissection is what? Fecal incontinence tells you what? The sphincter has been involved. So as will not leave the sphincter behind. T4 lesions in the lower third encroaching on the sphincter. Undifferentiated tumors. Don't go ahead and do an sphincteric dissection, ISR. Don't do that. As well as tumors invading the tuber rectalis and the external anal sphincter. Right? So what is the methodology? Either you do an open or a laparoscopic, very low dissection. Anal part, we said, anal anastomosis. The dissection of the distal rectal line may be an intersphincteric groove because here I don't have that rectum available. I'm encroaching almost on the sphincter. So what do? I go in between the two sphincters. What are the intersphincteric plane we talked about? The plane with the longitudinal muscle and the external sphincter. And to the medial is lying what? Internal anal sphincter. So I'm going into that plane. So that intersphincteric groove between the dentate line and the intersphincteric groove, that's subtotal ISR, or at the dentate line is partial ISR. So basically, we talk about 3 types of intersphincteric excision: the total ISR, the subtotal, and the partial ISR. Right? So intersphincteric groove is what? Remember intersphincteric groove? Where is it? It is the lowermost part of the internal sphincter. So that is leaving what? Just leaving a centimeter from the anal verge. Right? Dentate line, intersphincteric groove. What is that? Slightly higher up. Or at the dentate line, slightly more higher up. And you have to wear protective stoma. Let's look what we're talking about. So we are basically talking about going to the intersphincteric plane. Can you see this plane? Internal sphincter, external sphincter, and the longitudinal. So I'm going to excise from here. The growth is lying out here. I'm going to excise from here and go here. So either I can exercise up to here or up to the dentate line. So that would lead to what? That lead to the total, subtotal, and partial intersphincteric excision. This is what we're talking about. Partial. So if I go just 1 centimeter, I'm going to a total. If I'm going up to the intersphincteric groove, I'm going as subtotal. I do have the dentate line. It's a dentate line. I'm doing a partial intersphincteric dissection. Is that clear? So 3 types of ISRs. More extensive excision, I find it's gone to the rectum, it's gone into the vagina and the uterus. I can still excise it. I go in for pelvic evisceration, partial or total, or transfix operation. Here, basically, what you're doing is you're removing more organs along with the rectum. It could be all the organs inside the pelvis, or it could be part of the organ inside the pelvis. In the male, let's say if I'm going to remove the bladder and the prostate, then I have to do a what? I have to go in for a creating of a ileostomy, a nipple ileostomy, along with the uterine implant into it, or if I'm going to I have to make an ankyloscopy, right? So it is either part or whole of pelvic organs, and this is known as a partial evisceration or total evisceration, right? And the whole empty pelvic cavity, the whole thing is empty now, and the chances are that the intestine will fall into the pelvis and lead to adhesion formation. So what do I do for the empty pelvis? I pull in a rectus abdominis flap, right? It goes without saying that I have to remove all the lymph nodes, the internal iliac, the obturator lymph nodes, and the pelvic organs. That is pelvic exentration or evisceration. Is that clear? What about radiotherapy? Just a few words about radiotherapy. Just got a couple of slides remaining. As an adjuvant, it's always an adjuvant, either pre-op or post-op. Post-op does not have a major role to play, right? Pre-op neoadjuvant 5 days radiotherapy, we refer to that for downstaging, and surgery after 7 to 10 days. The problem with radiotherapy followed by surgery is that leads to a lot of bleeding because fibrosis is not occurring within 7 days. For that, for a larger period of time, a longer period of time. Just sterilize the lymphovascular invasion, do a downstage, and then go ahead and do a local excision. Or as a chemoradiotherapy. So either radiotherapy alone or as a chemoradiotherapy for 6 weeks and surgery after 6 weeks, right? Chemoradiotherapy, complete pathological response 20%, partial response 25 to 30%. So it is not a bad idea to start the surgery if it's T3, T4, and you find, especially T4, and you find it's not spread beyond just a few organs involved or just beyond that to the pelvic fascia. It's not a bad idea to start with the radiotherapy or a chemoradiotherapy and then wait for the surgery after 6 weeks, right? You can do a chemotherapy, the indications, neoadjuvant again, just like the radiotherapy for downstaging, or you can use a post-operative adjuvant, which is a better proposition than radiotherapy post-operative. So post-operative, if you want to give some kind of an adjuvant therapy, it has to be chemotherapy. Pre-operative, you got a choice between radiotherapy and chemotherapy. Is that clear? And the regimes that are used for chemotherapy, they are more or less based on 5-FU or one of the derivatives of 5-FU. That's capecitabine. Now, capecitabine is basically an oral form of 5-FU prodrug, which gets converted into the body into 5-FU. We all know that. So either it can be a capecitabine alone, or it could be combined with a biological agent, which is bevacizumab, right? So bevacizumab, you can be combined with the capecitabine, and that makes it a combination of a chemo along with biological agent. If you find the response to be adequate, this is an oral drug, can easily be given. You find the response to be adequate, I've written the dose, you can just go ahead and look at the dose. If you want to have, or you don't have an adequate response, what you expected, then switch to second line of drugs. That is basically the irinotecan, the oxaliplatin, and trifluridine. So these are the second group of drugs, second line of drugs, which are usually indicated in those patients where the capecitabine does not have an adequate amount of response. Or you can use a combination of drugs like combination regime, which is very common for colon and rectal cancer, the FOLFIRI regime, which has now become the standard or a very good standard for comparing the other regimes, the FOLFIRI regime, a combination of IFU, irinotecan, and leucovorin, right? Leucovorin basically is always given when you're giving 5-FU. It's a leucovorin rescue, known as a leucovorin rescue, which is an amino acid, which helps in the limiting the side effects of 5-FU. You want to do a palliative, even Hartmann's is not possible, just go and do a loop or ankyloscopy. Don't touch anything else, just make an ankyloscopy. The patient is already in stage 4 and beyond, you can't do anything for this patient, just do a loop or ankyloscopy. Slightly better condition of patient, you want to deload, debug this tumor, go in for Hartmann suppression. Or you can do an endoluminal stenting. We just talked about that. Or you can just do a chemotherapy or a radiotherapy in these patients. Helping what? Radiotherapy is probably helpful when you're talking about the T4, the stage 4 diseases, which palliates pain and obstruction of bleeding. Because chemotherapy alone, if it's given as adjuvant, it creates a lot of problems in the form of nausea, vomiting, and diarrhea. So that's not a very good option. Just using as a single drug as a palliative method in patients who have got stage 4 disease. Probably radiotherapy would be a better choice as compared to just chemotherapy, right? Targeted therapies are now being used basically against the vascular endothelial growth factor. They are also against the endothelial growth factors, or you have the BRAF gene changes or the kinase inhibitor. So all these are now being tried out and used at certain centers. These are the targeted therapies which are targeted at the rectal carcinoma, right? If you look at the results post-operatively, overall 5-year survival rate we already talked about that. After surgery is 50%, and the overall last time, remember, we talked about 67%. So it varies from 50 to 67% in patients who have got carcinoma rectum. The survival rate is worse in those patients. So these are specialized centers, specialized units. So we in a primary center probably will be having a worse 5-year survival. In the more distal, that means lower third, it's probably poorer. Due staging C, fixed as opposed to mobile growth and anaplastic growth. It's basically logical reduction. That these are basically growths which are the worst growths. So obviously the 5-year survival rate would be poor in these patients, right? Managing local recurrences, that is important. You've done everything. You've done a sphincter saving. Everything was done very good. Follow this patient and local recurrence, right? So the guidelines of the National Comprehensive Network guideline, we refer to the definition that is the Dutch group, which is usually adhered to now, which recommends that number one, the risk of recurrence depends upon the location of the cancer. Understandable. Treatment had no significant effect in the subgroup. Which subgroup we're talking about? In the subgroup where the cancer was stage 1 to 4 and located between 10 to 15 centimeters of the anal wall. That basically talking about upper third. So whether you're doing surgery alone or preoperative therapy plus surgery doesn't make a difference. So the choice doesn't make a difference. You can have any procedure, but just remember the procedure has to be a curative procedure. The rate of local recurrence in the region 225, we said up to 50% in the first slide. It is very, very variable. So higher after APR. Recurrence higher after APR because that tells you what? You require APR means what? It is only stage 4. Or it is basically T4 at least, not stage 4. I don't call it stage 4. T4 disease. So there the recurrence has to be higher. 80% within 2 years. That means the first 2 years are the worst. And presents as what? Either extraluminal growth or intraluminal growth, which is less common. And at the anastomotic site or luminal with PRP. There's usually an extraluminal growth as a recurrence, interluminal slightly lesser. Diagnosis can be done with a CECT, sigmoidoscopy, and the treatment has to be re-excision, or you can do a palliative radiotherapy, right? So this just brings us to the chart. I think you can go over this chart, and this chart is very informative. T1, T2, that is basically a stage 1, a stage 2, N0, M0. See, no lymph node, no metastasis. So I can carry out primary therapy like transcranial excision or TM, right? T1, T2, I just told you, local forms. Go through the areas, do it, right? T1 margins negative, just observe. I've done excision, I send a histopathology, the margins are negative, no problem. I just keep following up the patient. But if I find that these patients after the pathology report is a high risk pathological form or it is T2 on histopathology, then I have to carry out some kind of a primary therapy, like for example, transabdominal resection of the rectal cancer. That means LAR or very LAR or high AR, whichever. To start with, it is T3 or it is 1 to 3 with N1 and 2. That means any lymph nodes, any lymph node. Then I have to carry out a transabdominal resection of rectal cancer. Is that clear? So if it is any lymph node positivity, then I have to go in for a transabdominal resection, which is not said, it is basically LARs, the 3 types of LARs. And I may have to combine adjuvant therapy below to the chemotherapy regimes in the form of 5-FU, FOLFOX, capacity. And then I have to keep observing the patient. So that's the follow-up of the patient. So that gives you an idea as to what is to be done in these patients. Thank you. I think we're finished with the rectum, and this was the last topic on rectum, the rectal carcinomas. If you've got any questions, you're ready to ask them. If any questions, if not, then I think we can close down for today. Thank you. I'll inform you what the next lecture is going to be. So no questions? Okay, thank you.